Hi, my name is Justin Sheehy. I'm the current structural heart disease fellow at the Mid-America Heart Institute in Kansas City, Missouri. Today we'll be discussing a case of hypoxemia after LVAD implantation. So I have no relevant financial disclosures. So our patient is a 68-year-old gentleman with a history of an ischemic cardiomyopathy with end-stage heart failure. He's been on home inotropic therapy for the past several months, and as a result, has been planned for a permanent LVAD implantation for destination therapy. He does have comorbidities that include paroxysmal atrial fibrillation, type 2 diabetes, and CKD with a baseline creatinine of 1.5. So the patient was electively admitted and went to the operating room on August 20th of this year. He underwent a successful HeartMate 3 implantation, was overall weaned off of cardiopulmonary bypass without any complications, and had TE monitoring throughout the entire procedure. He was transferred to the surgical intensive care unit for ongoing care. And shortly after this, about an hour and a half after he was transferred from the operating room, unfortunately had escalating ventilator requirements with an increasing FiO2 and escalating PEEP, in addition to worsening hypoxemia. The ICU team quickly did a repeat TEE that demonstrated a very large right to left shunt through a PFO that was previously not identified at the time of the LVAD implant. So here is our TE images that demonstrated a very large right to left shunt, as you can see based on the color images on the right of the screen, without color here on the left. What you can see is that there's quite a bit of significant variation, particularly with ventilation, with continuous flow from the LVAD in the LV, significant influencing on the right to left shunting effect. So there was an urgent heart team discussion that was held with cardiothoracic surgery, the heart failure team that has been taking care of the patient longitudinally, in addition to our interventional team. Rather than reopening the patient's chest after his recent surgery, the decision was made to percutaneously close the PFO. Initially, our strategy, because of the large amount of shunting, we elected to proceed with a 35 millimeter Amplatzer PFO occluder that was originally placed. Is what we can see on the next slide is that there was actually a significant amount of aortic hugging with this initial device deployment, particularly is what you can see on the right of the screen. As a result, we elected to remove this device and de-escalate with our sizing down to a 25 millimeter occluder device. And as what you can see in this next image is that the device is flush against the intra-atrial septum. And our color isn't shown here, but there was a significant decrease in the right to left shunting immediately after implantation of this device. The fluoroscopic positioning is seen here, as you can see with our TE guidance, and then this LVAD that is in place. Overall, the patient did remarkably well after he had the device implanted. He was extubated and had improvement in his respiratory status over the next 24 hours, and was actually weaned off of all inotropic support over the next few days. He actually did well and was discharged on postoperative day 6, and overall has been doing well with his new device and had an improvement in his functional capacity overall. So a question for our audience is, what is the accuracy of identifying a PFO using standard TE methods? A, 75%, B, 85%, C, 95%, or D, 100%? And our correct answer is B, 85%. Traditional bubble studies indicate an accuracy of 85 to 90% in identifying a patent foramen ovale. There are a few methods that can improve the specificity of the test. One is by utilizing the eustachian ridge by injecting agitated saline from the leg, particularly using the right leg is our preferred approach. The patient's intrathoracic pressure can also be augmented, particularly using mechanical ventilation or by mechanically pressing on the abdomen at the time of the bubble study. Additionally, one trick that the surgeons will use at the time of an LVAD implantation to ensure that they don't miss a PFO, similar to what happened in our case, is the surgeon can actually manually compress the pulmonary artery, which markedly increases the right side pressure and increases the chance of identifying a right to left shunt as a result. So the conclusions and take-home points from this case is that very careful pre-procedural screening and intraoperative TE should be performed prior to LVAD insertion to rule out a PFO. Particularly in this case, there was a retrospective review of the intraoperative TE, and there really was no PFO that was seen at the time. So the constant flow of the LVAD can actually increase the shunting even from a very small PFO. As a result, PFOs are generally oversewn at the time of an LVAD implantation because of this phenomenon with the increase in right to left shunting. And then it's important to note that if this were to happen again, PFO closure can be successfully performed from a percutaneous approach relatively quickly in order to eliminate and decrease the right to left shunting and improve the patient's clinical status overall. So with that, I would like to thank Dr. Huber, who is our attending on the case. And here's our references if anyone has any questions. If there is anything, please feel free to email or call with any questions. Thank you.